Hi, this is Manos Brilakis from the Minneapolis Heart Institute, giving an update on the Progress CTO registry. The Progress CTO registry is a multi-center registry of chronic total occlusion interventions in the coronary tree that was started in the United States, where are the majority of the sites, 26 of the 28 sites. However, it recently expanded in 2 sites outside the US, one in Russia and one in Greece. The registry is currently funded by the Abbott Northwestern Hospital Foundation and has had a tremendous output in terms of helping advance our understanding of CTO interventions. This is an update as of a few months ago, demonstrating data in more than 2,000 lesions in 16 centers, showing that technical success was 88% with a major complication rate of 2.6%. Interestingly, it took all the techniques to achieve these high success rates, and the final successful technique was undergrade wire escalation about half, and undergrade dissection reentry and retrograde in about a quarter of the successful cases. There have been 29 published manuscripts from Progress CTO, giving a tremendous insight on the contemporary CTO PCI management. Here we'll review some of them that provide context for doing these procedures. The first ones have to do with the why we do these procedures, and like every other decision in medicine, CTO PCI should be done when the anticipated benefits outweigh the possible risks. And the benefits depend on the patient's baseline condition, specifically his symptoms, whether or not he's got ischemia, his myocardial function, but mainly his symptoms, as well as the likelihood of being successful, and this can be understood by using the Progress CTO score, which we'll review in a minute. It also depends on the risk, which is both acute in terms of the procedural risk, but also can be long-term for stenosis and stent thrombosis. And all these risks can be calculated by using an online calculator at the Progress CTO website. This is the Progress CTO score that uses 4 angiographic parameters, namely the proximal cap ambiguity, the lack of interventional collaterals, the presence of moderate or severe tortuosity, and that of circumflex as a CTO target vessel, to determine the likelihood of being successful during CTO PCI. When 3 or more parameters are present, success is about 77%, whereas 2 or less, success is more than 90%. There's also a score to estimate the likelihood of complications. And one of the things that became evident through Progress is that age has a major impact on the risk of complications. By increasing age has been associated with decreasing success rate in men, whereas not as much in women. However, when the multivariate analysis was done, the major predictor of complications was the older age, followed by longer than 23 millimeters CTO length, and use of the retrograde approach. Using these 3 parameters, there can be an estimation of the risk of complications that ranges from close to 0 up to almost 7%. There are several insights that Progress CTO provides in terms of the techniques used for doing this procedure. One of them is that lesion age does not really matter. Of course, lesion age is subjective, and sometimes we don't have accurate information on how old the lesion is. However, the median lesion age in Progress is about 12 months and the mean is 43 months. And what we found is that older age was not associated with significantly lower success rate, but success rate, both technical and procedural, were similar into the different age subgroups. Also, we found that having a previously failed CTO PCI procedure does not necessarily translate in worse outcomes, since technical and procedural success were actually similar with or without a previously failed procedure. Looking at more specific techniques, use of undergrade dissection reentry was associated with favorable outcomes, with high technical and procedural success. And the same was seen for using the retrograde approach, showing that the retrograde was slightly less successful than the undergrade only procedures, but also they were done in more complex lesions. Another thing that became very apparent is that the retrograde approach, although necessary and associated with high success rates, nevertheless it's associated with higher risk of major adverse cardiac events. There was a fourfold higher risk of MACE, mainly driven by higher risk of myocardial infarction and pericardiocentesis. So although it is very important, it should be done with caution because the inherent risk of doing retrograde CTO-PCI is higher than antegrade only procedures. And we also know that use of the antegrade dissection re-entry and the retrograde is more important as the lesions are more complex, as reflected by a higher JCTO score. We also found that the wires currently used for CTO-PCI are changing, but the Pilot 200 remains the more commonly used wire, followed by the Filter XT and the Confianza Pro 12, with an increase recently in the use of the newer composite core guide wires such as the Gaia guide wires. There was also significant variability in radiation dose for the patient in various centers. Although all these are experienced centers and achieve high success rates, there is significant variability which could be in part explained by different equipment, but also may have to do with the operator, different techniques, and radiation safety precautions. Similarly, there is some variation in contrast utilization, with some of the most important predictors of contrast are ad hoc CTO-PCI, use of dual injection and large guide catheters. However, on the contrast, having antegrade only procedures is associated with lower contrast dose. Overall, the mean contrast dose in Progress CTO is about 289 mL. Balloon uncrossable lesions is a challenging CTO lesion subgroup that can also be seen in non-CTO lesions. They represented 9% of the lesions in Progress CTO and were associated with lower technical and procedural success and required various techniques for treatment, including laser, granuloplasty, and various anchoring techniques. However, in the majority of cases, those more challenging lesions could be successfully recanalized. Having a side branch, either at the proximal or distal cap, is important because those branches may be lost. They were lost in about 1 in 4 cases in Progress CTO. And those in whom the side branch was occluded, could not be recanalized, did have higher levels of post-procedural myocardial enzymes, higher CKMB, and also they did have higher incidence of death during follow-up. In terms of intravascular imaging, it was used in 30-80% of 7 centers in 619 lesions, and it was used mainly for lesion optimization, about 2/3, but in about 1/3 it was used to facilitate crossing. Use of imaging was associated with high technical and procedural success and acceptable complication rates. So in summary, Progress CTO has provided a lot of knowledge regarding how this procedure is done in the current era at multiple sites, mainly in the United States, but now increasingly becoming international. It does show high success and acceptable complication rates. There are scores derived from Progress that can help get an estimate for the success and complication rates and facilitate the patient and the physician decision making. The prior failure and the lesion age are not associated with lower success, but high success can be achieved even in those lesions. About 9% of CTOs are balloon uncrossable. It is important to have an algorithm for targeting those lesions. Of course, side branch loss is an undesirable side effect of CTO-PCI, and every effort should be made to recanalize all branches. And finally, there is wide variability in contrast and radiation use. The Progress CTO registry is continuing. It's currently being moved to the Minneapolis Heart Institute from UT Southwestern. And we remain highly committed to helping understand further the success, complications, and indications of the procedure, and encourage you to participate in the registry. If you're interested, please email us at esbrilakis@gmail.com or go at our website, the Progress CTO website, www.progresscto.org. Thank you.